infection control practices in India, 360-degree. I'm the trustee from AMR Trust. Dr. Abdul Kafoor is the main person who's running this AMR Trust. Good evening, sir.
So on the device is mute. Its device is muted.
Good evening. Yeah. So thank you, panelists, for accepting the invite from AMR Trust to discuss with us the core agenda or the issue on infection control practices in India. I would like to introduce our panelist. We have Dr. Clive Fernandez, who is a global expert in patient safety with a career spanning over 20 years. He's currently the head or group of COO and medical director for WOCOT Hospital for the past 11 years. He's also a consultant with JCI for over 17 years, and he has trained staff and provided quality accreditation consultation to organizations across 40 countries. Welcome you, sir. We have Dr. J. Jayalakshmi, who is the professor and HOD of microbiology at Powai Medical College and Hospital. She is also an ISQA. She has also done her ISQA fellowship and also an MBA. She is also an NABL and NABH lead assessor who is taking care of infection control practices as a secretary in Powai Medical Hospital. She is also the lead representative of CAHO for diagnostic. She was also the program director for CPHIC certification program ICAM and iComply. Welcome you, ma'am.
Thank you. Thank you, Dr. Yamuna.
Thank you, ma'am. Today we have Dr. K. Kolandaswamy with us, who has spent a lot of years in government setup and who has been the lead director at the Directorate of Public Health, who has been an important person in framing and being part of COVID task force for the entire state of Tamil Nadu. He had held many posts in public health, so he is the right person who will be today with his experience sharing us the infection control practices, how we can take it forward at the public level. Welcome you, sir.
Thank you, madam. Thank you.
We have Dr. V. Ram Subramaniam, the Senior Consultant Infectious Disease at Apollo Hospital. He is the director and co-founder at Capstone. He's also the adjunct professor at Ramachandra Medical College for the MGR Medical University, Savita Medical College, and adjunct professor infectious disease for Apollo Hospitals Education and Research Foundation. Sir is the lead for the stewardship practices across India through ICMR projects. Sir has got many abstracts and poster presentation. Sir is my mentor. I welcome you, sir, on board. So starting with the topic, healthcare-associated infections are among the most frequent adverse events which is occurring in the context of healthcare delivery and mostly caused by multi-drug resistant organism, which is a significant burden on healthcare system, which also leads to increased cost. And the data available says that the burden of healthcare-associated infection in a low and middle-income countries like India is very high. And the pooled prevalence is around 15.5 per 100 patients, which is double there compared to Europe and US. And mortality among patients affected by these high is supposed to be 24.4% and increasing to 52.3% if patients are admitted in ICU. And among people who are infected with MDROs, the mortality rate is 2 times to 3 times higher. The situational analysis of the implementation of the infection control program worldwide, which was conducted by WHO, and the summary says that only 54% had national IPC program or operational plans on paper, but that had not been implemented. This is the real scenario or the real life scenario, even though programs are on paper, but nothing there on the floor and nothing is being followed. And or that they were being implemented, even if certain countries only in few healthcare facilities, where India is one among them. So I would like to direct this question to Dr. Clive. Which are the common gaps do we see in an infection control program in our country, and how to fill in these gaps?
Thank you, Dr. Yamuna, for the kind introduction, and hello to my colleagues and friends. And thank you, AMR Trust, for the opportunity. It's a very good question about gaps, and opportunities. And as you just said, I just heard you, I was just taking some notes, and you just spoke about most of the things are on paper, nothing is on the ground. And it brings me to this question, that why is it like this? And then, we have all the clinicians here, so I'll be doing the administrative jargon. So I have two syndromes, the CH syndrome, which is the chalta hai syndrome. It's okay, and so I didn't wash my hands. So what happens? Chalta hai, and bundle compliance is not there. People say, okay, these are things that we can't do every day. We need to do this during the accreditation. So we have panelists who are coming from NABL, NABH. I myself are from JCI. Dr. Ram has been in this from 2005. So we all know, people say, oh, let us keep this aside. Let us do it at the time of accreditation. So the gap, I think, is the walk the talk bit. For many, many years before accreditation came in, we did not know what to do, and so we did not do things. Now we know what to do. Now our challenge is why to do it. It does not affect me. And that's where I bring in this. People in healthcare have spoken so much about the checklist manifesto. They actually made Atul Gawande a millionaire, by buying his book. And, it talked about the checklist and airlines. But one thing which is very different is, in the airlines, if the pilot does not follow the checklist, when he says cabin crew cross arm doors and report, before that happens, the plane does not start moving. In healthcare, you talk about bundles for anything and people will put all the ticks in the night because that is for the quality person tomorrow. Because in healthcare, if I don't do what I am supposed to do, the harm does not come to me. So if you talk about why are these gaps there, it's the chalta hai syndrome. The second syndrome is, QTJ, quality department's job. Hand hygiene, the compliance is not good. Oh, that's not my job. That's the quality department's job. So we have to break this whole barrier that quality is someone else's job. So as you rightly said, we have most of the things on paper. We will never have anything on the ground till we don't break this stigma. I remember pre-COVID, people did not know hand hygiene. People did not know doffing, donning. People did not know screening. The day healthcare became like airlines, that if I don't do it properly, I might be a victim. During COVID, people used to do hand hygiene in their sleep. I'm quite sure of it, while dreaming also. It was, so it's just that whole attitude. So the mindset has to be changed. So this is the gap. Today, we have experts. I think we have in India, we have the best talent. On this panel itself, I think you said Kulanda Swami sir actually gave the guidelines for the task force. Dr. Ram is an institute in infection control himself. But still, when you look at, people washing their hands and, 30, and, and then the problem is the disconnect. I'll take another minute here to talk about the disconnect. You ask any organization, as an auditor, as an assessor, can you tell me what is your hand hygiene compliance guideline? And they'll proudly display graphs of 85 if they are rational people, and otherwise they'll give you 95 and 98%. And I remember this article in Lancet which actually talks that the best of best, when you look at effectiveness to time and technique, is not more than 45%. So the whole idea is, the mindset and this whole data disconnect. I call it GIGO, garbage in, garbage out. So if you're coming to, what is the gap? The whole gap is in the mindset. We need to change. And I think here leadership will be the people who will play the bigger role. But that I don't talk now. It's just about this mindset here.
Thank you, sir. Ram sir, do you think that the gaps, as Dr. Clive mentioned, is more about leadership role and more about accountability for the people who work on the floor? How do you think about the resources being allocated for these? Is that the reason that there is still a gap for implementation in certain setup of healthcare facility, like in terms of a dedicated infection control professional who has to be available, fully trained? Is that an important reason for these gaps?
I completely agree with what Clive says. There is no substitute for accountability. Unless each and every person is made accountable for his compliance, we are not going to move forward. Of course, it is very important. As coming close second is the responsibility for the administration to ensure that this is done, either by incentives or penalization. So the administration should invest in infection control, but that is fine. It is the behavioral modification which is required from all Indians with regard to accountability and ensuring that they do their small bit of things to improve the infection control scenario. So whatever is said is completely true, but of course, administration comes a close second.
So the most important aspect by which we can close a gap in these practices is making everyone accountable for the work they do, and also have a very strong leadership so that if it's raised as a problem, it gets sorted out then and there. Thank you both of you. So again, there is one more question which arises, that even though the WHO data says that we made a good progress of infection control practices during this COVID season, but still there are major gaps happening in the primary care. So I would like to ask Dr. Kodandaiswamy that how to intensify or strengthen these kinds of IPC practices in context of this resilient health system like primary healthcare settings.
Good evening to all of you. Thank you for organizing this important program, particularly Dr. Abdul Ghafoor and Yamuna Madam. So as you rightly asked, so the gap, mainly not only in primary care, at every level, including the community setting, the behavior is very, very important. So say, for example, during the COVID-19, everybody used to they wash hands and wear mask and other things. But now, even when the people are going to hospitals or crowded areas, this practice is not followed. So the behavior change is very, very important. And also in most of the primary care setting, so the training also is very, very important. When the new entrants come, so there is a system in the government healthcare, primary healthcare setting, the National Institute of Health and Family Welfare and other the family welfare training centers in the state level. But still, so I feel when we organize the training, so one circle, then again the new batch comes. So there are some kind of the inadequacy in entirely completing every member of the primary healthcare team in doing the infection control practices. That is very important. Then again, physical infrastructure also, maybe the primary health centers in many of the places, the physical infrastructure, equipment, still a long way. Although there are protocols are in place, and again the indicators, monitoring the indicators, these are all the issues in primary healthcare, but we need to rectify. But the COVID had changed a lot of the practices. But after this COVID, again, as I already mentioned, so people are reverting to the same old practices. This is the problem.
Thank you, sir. So you are claiming that for private healthcare centers, not only private, but to the level of primary, secondary, and tertiary, we need to invest in the availability of the infrastructure and also a behavioral modification for the people who work on the floor.
Yeah, definitely.
Yes, sir. Thank you. Again, the WHO says that even though during COVID, the IPC program, the implementation or adaptation remained significantly constant at 61.3%, but there was a significant increase in the percentage of countries where they started appointing a full-time infection control professional, and it moved from 21% to 72.6%. So the question to Ram Subramaniam is that, where do you think we still need to improve in terms of IPC practices in hospitals as a country whole? So we know that there is a reporting mechanism which is happening in pockets of hospitals in private, few of the government hospitals driven by ICMR, also done by the National Family Healthcare Program Committee. But where are we still lacking? How as a country we can improve on these IPC practices?
I think this again comes back to the answer to the first question, that every person needs to be made accountable for doing his responsibility with regard to hand hygiene and other practices. I think there is no substitute for that, and unless that is impressed upon, we are not going to get anywhere else at all. It is still, as Clive said, all on paper. The NABH assessment or the JCI is still mostly on the paper. Once that survey is over, we are back to doing our old ways, whether it is single-use devices, whether it is hand hygiene compliance, whether it is antibiotic stewardship or surgical prophylaxis, it's all the same. So I think that needs to change. That will change only with awareness. Administrative, the administration has to wield the rod and ensure that things are done. The second thing I feel we need to do is customize practices to suit our needs. We are still cutting and pasting. We still say we need a negative pressure room, 4 for each hospital. What will you do if you don't have? Oh, I will send them to another place. Is that what we do? No, that is again on paper. We need to have a system where we say that no, our hospital cannot afford a negative pressure room. We are not living in an ideal country, not an ideal hospital. So we need to customize things based probably on WHO or other recommendations, or we have to evolve our own recommendation. I'll tell you one thing which happened is the surgical antimicrobial prophylaxis. Till about 3-4 years ago, surgical antimicrobial prophylaxis was only related to cefazolin and cefuroxime and maybe amikacin for certain abdominal surgeries. This has been there for the last 25 years. But for the last about 15 years or so, I have been noticing that our infections were predominantly gram-negative, especially the infections below the diaphragm, surgeries done below the diaphragm where there is a risk of ESBL, which is very prevalent. So I have had several dialogues when I used to attend conferences with the infectious diseases physicians elsewhere, who claim that only gram-positive cocci colonize the skin. Gram-negatives are not a problem. You don't need to worry. But in India, keeping in mind the cleanliness, the problems with water and lack of bathing, the humidity, especially in Tamil Nadu in India, gram-negatives are a problem. It is not like the West. So we changed, Yamana, you'll agree that we changed our antibiotic policy for surgical prophylaxis way back almost 10 years ago, when we said that it has to cover for ESBL organisms, and that did help. And only recently, about 2 or 3 years ago, the ESCMED has said that no, we need to cover ESBLs, the resistance is rising. So this is something which we as Indian practitioners have to come up with guidelines to suit our needs. And lastly, you need to have government mandates to have periodic, whatever, whether it's an audit, whether it is a penalization, something has to be done to make sure that people adhere to this. We use shortcuts, we use, again, chalta hai, that compromise is a huge problem with the Indian mentality, has to change. Certain things you cannot compromise. I think that is what the government, the administrators have to mandate.
So what do you think about the role of surveillance, monitoring, and reporting it as a team? If that is driven by the government, would that bring some practice, or would that mandate the people on the ground to establish infection control practices in that place? Would that help?
Absolutely. Again, we say that, oh, we are too busy. We doctors can't do this. Even now, you know that in Apollo, we are fighting with the demand of notifying cases of tuberculosis. It is a very important part of controlling tuberculosis. Unless we document tuberculosis, how are we going to assess or put interventions in place? But we claim, oh, we doctors are so busy, we can't do that. You need to figure out a way. That's why I'm saying you need to customize based on your institute, based on your practice, based on your hospital. You need to come up with a solution to ensure that we report. If the government says, please do it, because otherwise, how are we complain about the government's public health initiatives, but we don't contribute to it, So it's the same thing, whether it is income tax, whether whatever, 6.5% of people in India pay income tax. And all the measures are targeting the 6.5 and, squeezing them dry. No, you need to ensure that the problem is not with an infectious diseases department, an infection control department, or quality control department in the hospital. It is every person, every doctor has a role to play. So the mindset has to change if we are going to improve. So it's not a question of just money or awareness. It is a change in mindset of the healthcare workers.
So as a regulation way, we can request for surveillance, monitoring, and feedback. But again, it's all we all talk every time is about accountability and coming back to the behavioral modification and asking people to be more accountable for what they do. Same question to Korandai Sami sir. How can we improvise these practices at a community level? We as a country are very good, even, I mean, because of all the programs, the communicable disease program, national program like TB program or the national malaria prevention program or the dengue control program. We are very good in reporting these communicable diseases as a country whole. But how can we bring these infection control practices, a reporting mechanism in the community?
In the community level, we go by the experience of the swine flu, COVID, dengue. The earlier the cholera and other infectious waterborne infectious diseases, the community involvement and the role of the field workers in educating the community and involving them, and involving the other departments like the water supply, rural development, municipal administration, the development departments are very critical. But unless we involve the community, then it is very difficult. Whether it is a hand hygiene practice, it's not only in the hospital setting, at a home setting, at the various kinds of eateries, hotels, and eating establishments are there. The practice. So everything is very important. And the role of the community, if we look at the COVID also, the ventilation played a very important role. So if we take the hospital design, so now it is a power dependent type of hospitals. So if you look at the hospitals designed some 50, 60 years back or 100 years back, so the height of the roof height, the space, the window, the door window space to the room, the ward is very high. So, but that has changed over a period of time. So, involvement of engineers, involvement of the air conditioning and engineering people in infection control is all very important. So, involving community, educating the community, even in surveillance. So, we did a project with ICMR in Tiruvallur district. So, involving the community is very important for early detection of outbreaks, infection control, and most of the infections, as we know, the poor hygiene and poor sanitation, and also the contamination of the water happens. So, at every level, as Dr. Ram Subramanian sir was telling, so every individual, whether irrespective of their profession or the place of residence or their role, they have a very definite role in controlling the infection and the other kinds of epidemics, pandemics in the community. That's very important.
Yeah, sir. Well said, sir. I mean, that's the main WASH criteria which the WHO also promotes worldwide. I'm not aware, maybe the panelists can, can share their experience. FSSAI norms, when we walk into the kitchen, there are certain guidelines which has to be looked into. Have someone, when walk into the kitchen, really walk and see whether the water supply for hand hygiene, is it available, where people cook, where people eat, where people consume. Is there a number of availability of wash basin which has to be provided in a kitchen where they cook and where people consume? Is that been ever looked into when people go out to do an audit for these places? Is that a mandatory role? Because that is what is very important to prevent such outbreaks or epidemics happening in the community. What is say about this, Dr. Clive,
Yes,
Dr.
The
ma'am, you can.
FSSAI is very clearly defined. The every eating establishment, they have to register and they are to be trained. So, and this kind of it is mandated. Disease control is one of the important role these food safety officers and the designated officers, they have to carry out under the FSSAI. But one positive trend which is happening, the people are now asking for, if the hotel is not hygiene, if the eating establishment is not hygienic, then the people and the environment in which they are sitting and the food is served and the people who are serving the food, then that business doesn't go well. So it is the people's preference for good facilities now making them to improve in all spheres. But still, we go at the backyard of any eating establishment, even a star hotel, if you look, so if you go to the backyard, you can see the flies, the breeding of Aedes mosquitoes, and there are so many problems. Still, they have a long way to go and improve. And also the storage. Recently, all of us must have read about it. So some
Yes.
food items like this egg-based preparations, if they store it improperly, then that causes the shawarma kind of food items. They cause a deadly infections, and even a healthy adult come to the infection. We must be very careful in the eating establishment, particularly the institutions which are storing the hotels which are storing food for a long time should be strictly monitored. That is very important.
Thank you, sir. Because we do see that the antimicrobial resistance, we do have studies, case studies published. It says that AMR can not, it not only gets transmitted only in a healthcare setup, it also gets transmitted through these public health areas, or it can also spread in the community through improper sanitation, water, food, and the raw food we consume. So that's very possible. So we need to take care of these areas very well. And as you mentioned, sir, we need to involve a multidisciplinary people, either in the construction of a hospital building or a construction of a sanitary area like a kitchen. Then we have to be involving the engineering people, the necessary people who would give us the guidelines before even we begin our store or before even we begin the functioning. The next question is, the WHO estimated between 80,000 and 180,000 healthcare workers lost their lives to COVID-19 globally between the beginning of pandemic and towards the end of May 2021. So my question to Ram Subramaniam, sir, how to strengthen focus on occupational health?
Occupational health, I think, has come a long way since the inception. I remember I took my hepatitis B vaccine way back when I was in my final year in the mid 80s. And since then, again, we have come a long way, but it is still focused only on hepatitis B. The government stresses on hepatitis B, but the importance of when a medical college student enters the medical college, the first year, he should be completely screened and vaccinated. We still haven't got to this as a standard procedure in all colleges. There are some colleges which do it. Similarly, the nurses and doctors are looked up as probably those who need some kind of protection. But what about the allied staff? There's always a confusion. If there is a ward secretary looking after a patient where they have patients with H1N1 or say COVID, they were not protected before. What about chickenpox? What about people specifically working in pediatric units or OBG, obstetric units, people who may have measles, mumps, rubella, or chickenpox? So these are not taken care of. And lastly, the contract workers who do actually the sad part of cleaning the hospital, they are not covered by any protocols. So one, I think we need to come up with protocols, and the government, this is my request to the government, that they should come up with policies for all hospitals to mandate that the staff working there are protected. Similarly, needle stick injuries protocol. This is improved now. NABH coming in, JCI coming in. There are a lot of changes, but there are still large parts of the healthcare which are left unattended. So only with proper protocols which are mandated by the government, this is going to change. Otherwise, the contract workers will always be neglected. The poor nurses who probably may be working in smaller hospitals will be ignored. It is an investment which is very, very necessary.
The role of personal protective equipment, sir, as an occupational health. So we see that many places, they run out of PPE. Of course, all of us ran out of PPE during COVID pandemic because there was a huge demand and less supply. But what about having personal protective equipment all the time available for the healthcare workers?
See, again, we are trying to ape the West. We do need, but COVID showed us. I used to see so many people wear the regular surgical mask, on top of which they used to wear the N95 mask. There is ignorance of the proper usage. The idea of an N95 is to have a snug fit on your face. The poor nurses who have, small body habitus and small face, wear a large N95 through which, I used to say a lizard can go through your N95 by the side of your nose into your mouth. The area is so large that, COVID won't have a problem at all. So we don't do things the right way. We don't get the proper size fitted, the fit testing done. Things which actually this is what I said, customize. You need to apply things I'd rather wear a tight fitting, a surgical mask than wear a loose floppy N95. So personal protective equipment, yes, it is necessary, but as I said, we need to customize things to suit our population and how we can apply them better.
So where to write a chapter on this for customization of infection control practices for different settings. I think that should be
it's
the
very
way
important, very important
about it. High resource setting, limited resource setting, and very, very less limited resource setting. So that's where we need to customize. Even as an auditor, when they come, we all go with a checklist that this is what is mandatory and this is what we are expecting. But what can be done by the organization has to be looked into. Thank you, sir. So talking more about the resources. So the next question goes on to the resource requirement. Between 2015 to 50, the antimicrobial resistant cost is $4 billion per capita. And according to the Organization for Economic Cooperation and Development, the implementation package of including improved hand hygiene and stewardship and enhanced environmental hygiene in healthcare settings always reduce the health burden of AMR by 85%, while producing savings of 0.5 euros per capita per year. And hand hygiene and only environmental hygiene would reduce the burden by at least 40%. So Dr. Clive, how do you prioritize such resource allocation for infection control practices or invest in infection practices in private hospitals?
This is a question, people can write a book and I'm supposed to answer this in 2 or 3 minutes. So I'll just cover, the very bird's eye view. But I would like, because we just spoke about low resources, high resources and middle resources hospitals. I would like to say that's a myth, because resources is the means, not the end. I have to go from place A to place B. I don't have resources. I can't go by a Maruti or an auto. If I have resources, I go by a, Audi or whatever. So resources is just the means. But coming back to, how do we prioritize? So for any healthcare organization, it's very simple. You fail to plan, you plan to fail. Now, when you talk about resources, a lot of times the first thing that goes into people's mind is money. Resources is much more than money. It is money, it is manpower, it is material. So when you plan resources, the money part, we have our budgets, the operating budgets, the capex. The capex is okay. I'm going to get some money. We spoke about negative pressure rooms. We don't need it, or we need it. Certain accreditation needs it. You need to put it in the budget. So those come into the capital capex, which are budgeted in advance. Then you have the operational cost, vaccinations, staff, healthcare, training. There are so many things. So those are the OPEX. So that is about the money. Material is another thing. But now coming to your question, how do we prioritize? So there is something which is called a risk assessment grid, because no matter how much resources you have, you will always have many more things to do than your resources can afford to. So we call this a risk prioritization or a risk assessment, where for everything, and this risk assessment depends on, are you a primary healthcare, as Kolandaswamy sir said, or are you a tertiary accredited or quaternary hospital where Dr. Ram sits? So it depends on the type of organization you are. It depends on your community. It depends on the type of patients you serve. It depends on the type of services. There are multiple things that come in. It then looks at what is the probability of something bad happening. You grade it. When that happens, what is the outcome? And the third is, the organization's response, how you plan to respond. So the risk assessment tool, I believe, is the most important tool which helps people prioritize and put their resources in the right place, because guidelines are there. We don't need to ape the West. I totally agree with Dr. Ram. So Dr. Ram, I actually remember in the beginning of COVID, people even took the mask and they used to dry it in the sun for 5 days and wear it again. So, we've had so many products. So there are so many things which keep coming up. But once you've prioritized, follow evidence-based guidelines. So, the risk assessment, and yes, your infection control program is not only patients. There is a myth. It is, most of the people think infection control is patients, and that's why Dr. Ram just said what happens to the ward secretaries, what happens to the other people. So infection control program needs to encompass and cover everyone, including your mortuary, your garden, your contract staff. So the scope of the program, the risk assessment helps us, and then we prioritize.
Thank you, sir. Over to Jayalakshmi ma'am. Do we have any made or created risk assessment matrix available in our country where we as a team can share it with people and tell them that this is how you have to do? Is it something available?
Thanks, Dr. Yamuna, and thanks to the AMR Trust and Dr. Abdul sir for this opportunity. It was wonderful to be listening to all of you so far, and very well, in a well conducted and discussed session, I would say. So, looking at the risk assessment, I can't see any structured risk assessment tool available in the country as such. But if you would see ICMR, a guideline or the NCDC guideline, it does mention about how you do a risk assessment in terms of assessing the risk at site to see what PPE would you use. In fact, it was very, very popular during the times of COVID when you had a risk assessment based PPE chart put up in every area, which had given people some kind of some kind of directive on what they should be using, where should they prioritize, what should they use where, etc. So, like Sir Dr. Clive did mention about risk prioritization, definitely looks at three components only. What is the severity or the impact of this particular risk that would happen, and what is the frequency of its occurrence, as well as how prepared is the system. So there are only three components that you take, and then you see and you prioritize or you list them all. Take every issue as a risk, and then you start to list them down and give them scores. And when you have the scores for all the three multiplied, and then therefore you have your risk, prioritized as high priority risk, or in medium or a low priority risk. So when you start to look at, and you will see that 20% of this problem, when you solve, you kind of solve the rest of them as well. So this is by the 80-20 rule, where you start to address this 20%. Most of the time, it's looking at how you train people, how to restructure or redirect your resources and make available certain things. Only very few of them requires a complete structural change, etc. Most of the things require a training and making available a modified resource in that facilities. So that's what it would require. So if you look at these guidelines of Indian guidelines that you would see, so it would give you on, in fact, the NCDC has a small table also in its booklet of 2020. It gives a table on how you also look at, the risks which are structural related, the process related, and each one of them, so that it kind of says, but it does not give by scores, but it kind of says how severe the risk is, just the severity score is given, as a qualitative, not as a quantitative, but it is definitely there. So we could use anything within our own systems and facility and see how it might be, implemented in our facility. So, but like Dr. Clive also mentioned, and Sir also was mentioning, that risk assessment becomes the basic for structuring your program. If you do your risk assessment based on your data that you have, and then you prepare and you do that, so you will be able to structure your infection control program for the next year. So you will know what to prioritize the next year. So your risk assessment becomes the basis for your program itself. So it has to be done very well. So JCI has a very good white paper on that, and it's available, freely downloadable. Of course, you can use them, but of course we also can use on-site application of for risk assessment and see whether it would be useful in our own settings.
Yes.
Dr. Yamuna, can I add one comment on this?
Yes,
I
yes, of course.
totally agree, but I would like to play devil's advocate here, and I would write, very openly say one size doesn't fit all, so the harm in this, tool being there is, people then just go into the copy-paste mentality. It would be better if people learn the methodology of what they need to do, that is much more important. So, and I'll give you a small example. When we talk about medications and high alert medications, there is something called the ISMP list, which was supposed to be a reference list where you pick up 5 or 7 medications which actually have caused harm in your organization. But hospitals across the world, they took the ISMP list and made all those 300 medications high alert. So their whole pharmacy looks like a colorful yellow, so they say nakal mein bhi akal chahiye. So that is why I would say it is better to teach the people the methodology, otherwise, and totally I agree with what Dr. You said, but I'm just saying we have to be careful, because I've been on audits in so many places where people, when they get these things and they copy and paste, many times they forget to even remove the name of the organization from which they've got it. I've seen that. So that is one risk of, having tools which you apply without actually practically thinking through it.
Thank
well
you, sir.
said,
Thank
sir.
you. Yeah, that's well said, sir. So as a organization, as ma'am mentioned and Dr. Clive, sir, you mentioned, is that you need to have a focused monitoring mechanism in your organization and identify your own risk. But when you identify your own risk, how to categorize, as you mentioned by Jayalakshmi ma'am, is that look into the severity based on the outcome of your patient, the frequency of occurrence of this problem to you, and also look into how your system is prepared to handle this problem. And based on that, you need to have a risk matrix and scoring system, and then allocate your resources, which is the primary part where the management has to look into that. How can IPC can be brought into practice on board? So moving on to the next question, which is in continuity with this, is that resource allocation, outbreak analysis, we somehow scaled up the entire country, the entire world, analyzed the situation of COVID pandemic, even though it was a new thing for all of us. We scaled up all our practices, we did an outbreak analysis, and we kept or set up thing in place during the COVID pandemic, and we handled it very well. Even though the Western world also struggled to handle COVID a lot, India played a very pioneer role in handling it, either in terms of prevention, either in terms of control or vaccination program. We did very well. The next question to Korandai Swami sir is that how are we prepared for a new epidemic or pandemic? In other words, what are the emergency response plan do we have right now in our state or in our country?
Actually, the COVID-19 has taught us, all of us, a lot of the lessons. In that, how quickly we can emergency beds and other things, the ICU type of bed facilities, how quickly we can expand, so that the whole country experienced, and also the shortage of PPE manufacturing, including ventilators, the local companies indigenously manufacturing ventilators, PPE. So the textile companies manufacturing, and all, for example, including we taught the pharmacists and nurses how to prepare this the surgical spirit for hand washing, so that that kind of lot of the preparations the COVID-19 taught the experience for the entire lot of government as well as the private healthcare sector. But in my opinion, so the lot of work had been done, particularly the government of India. I think Jayalakshmi Madam must be knowing, in government of India, they have upgraded most of the microbiology departments in medical colleges, particularly the diagnosis for the virology diseases, and in every state. And the National Institute of Communicable Diseases has been renamed as the National Center for Disease Control, and they have collaboration with the CDC Atlanta also. So the assessment of the laboratory facilities, upgrading the laboratory facilities, and the reagents, the standardizing the reagents for testing. So all these kind of activities are going on. But what I feel from public health perspective, still the access to the higher end laboratories. So, say for example, we are facing a lot of problem. For example, this AES surveillance. The surveillance is one issue, So that is why, because of the inadequacies of the laboratory only, the surveillance is mostly based on the syndromic surveillance, so be it ALI surveillance or AES surveillance. And then on only we are able to go for the diagnosis. In a project done in Krishnagiri district and the Nilgiri district, collaboration with the NCDC, Delhi CDC, Atlanta, and Manipal Institute. So still, out of the acute febrile illness cases, AFI cases, with the best facilities available, under project mode, we are able to diagnose only somewhere around 55 to 60% of the infections. The cause of the causative organism had been identified. The rest of the 40% of the cases, we are not able to identify. That is the case even today in a major government medical college, or even a very good private facility with private hospital, or a private medical college hospital with all kinds of facilities. So in my opinion, so the strengthening of the laboratory facilities need to go a long way. Also, the cost of the laboratory test, that is the cost is very, very prohibitive cost, which is not affordable for a common man to. So we have to develop some kind of mechanism for standardizing the cost. Maybe more tests may be brought under the insurance the cover. So now some tests are brought under the insurance cover, but all that are not under the insurance cover. And if we broadly look at in the same context, the dentist, in any dental clinic we take, so they have a high level of protocol. And if you look at an ophthalmic clinic, they meticulously follow the protocol. And we look at the neonatology department, the neonatologists, they meticulously follow the protocols. But that is not the case with the other, most other departments. So the same, we should learn a lot of lessons from these three specializations, and the other specializations should follow. So these are all the inadequate, although a lot of preparations are being made and continuously, and our One Health approach is also being done in collaboration with the veterinary department. Also, there's a lot of coordination and developments are taking place, but still they are inadequate to early diagnosis of a major infectious disease, be that Nipah virus, or we struggled a lot when the EVD, the Ebola viral disease came. So all these things are really a challenge. And also the vaccination, international travel guidelines, and the quarantine units in the seaports and the airports. So many of these, since there are no diseases, so many of the quarantine centers had been dismantled and converted into other facilities. So now slowly the government of India is one by one re-established quarantine centers. These are all the activities are going on, but still EMR under the DGHS, they are coordinating all the efforts, but still a long road to go ahead.
Just adding on to
Well
what
said.
Dr. Kolaneswamy sir was mentioning, in the medical colleges, it's now mandatory that you teach all the undergraduates on preparedness for any kind of a pandemic. So there is something called as a pandemic module that all medical graduates have to go through. And there are also, from I think 2021, October 18th, I guess, onwards, the HIC committee is a must and a mandate for all medical college hospitals and healthcare institutions, along with an AMS program. So they also ensure that there is a fully functional team committee working, as well as teaching and training the allied sciences professionals, as well as the nursing, as well as the clinical pharmacists also. So that's a little bit of an upscale that's happened. So to help both to address AMR issues as well as to handle any kind of a pandemic, so that there is no chaos at the time when there is. So they kind of tell them and help them in understanding based on case-based scenarios on what we've learned from COVID and apply it. So it is still continuing when we are still teaching our students this practice. And I totally agree with the Kolaneswamy sir on how the microbiology's laboratory has upscaled. I was one of the 10 to 20 assessors who were doing the assessment for most of the laboratories across the country during COVID to empanel them for performing the molecular testing under, so that they get approval from ICMR for testing. So I have seen the growth of testing laboratories from nothing to so much of so much well established in across the entire country. What started off as a 5,000 rupees per test or 4,000 rupees per test, when the COVID was coming to an end, it was almost like 400 rupees to 350 rupees per test. So the test prices have come down because there was a need at that time. Now a lot of laboratories have started to look at the same laboratory settings for testing others. Many of them have not. Thankfully, this has upscaled our laboratory setups across the country. If not for COVID, for others also, we are slightly prepared, I would say, in the laboratory aspect of it, because at that time we had nothing in molecular tests. Now we have something, and there is a little bit of experience from all the clinical professionals as well as the laboratory professionals. The cost has also come down, so they kind of know how we can handle the situation in the laboratories as well. So that is one good thing that's happened. And the centers which got upgraded to sequencing have started to look at newer diseases. So if you would see, the new diseases that are identified now that is not taking longer time, does not get sent to various other centers to get to be confirmed. It's getting done in our own centers. So that is what the COVID has helped us do. So we are slightly prepared, but I don't think we should have any more pandemics.
Well said, ma'am. So thank you for that response. We have definitely scaled up. Emergency response plan is possible only when we know what is coming around for us, and scaling of microbiology laboratory and accessibility of the people to test what they are suspecting plays a very important role, even to begin with the emergency response. Thank you for that, ma'am. And also catch them young, teach the new generation when they enter into the healthcare system as a student, and teach them right from the beginning how to handle these situations. Thank you. Ma'am, I also would like you to add your most challenging scenario you have ever faced during implementation or creation of infection control policy, because I know that southern region you have been doing a lot of work, and I would like Dr. Ram Subramaniam also to add to it that because you were the people who began these practices in a healthcare organization, just share with us the most challenging scenario.
So I was going to say?
You begin, ma'am.
Yeah. Okay. So the most challenging was convincing the stakeholders. And like Dr. Clive was mentioning, men and material was very difficult and always difficult to get. So identifying the number of person and number of people for the activity and allocating the budget for the program would become a huge challenge for us when you start to look at implementation. Okay, why would we want to do this? Once there was a scare, yes, everybody did. And once that's gone and everybody would want to question, you will see the hand hygiene rates are no more the same as it was during the COVID, like you also mentioned sometimes back. So that was the most challenging thing. And also the attitude of healthcare professionals, the compliance to practices. That is another challenge in implementation. They know what to do, how to do, but they forget to do or not to do. So it's just that they would say, oh, it's not available or not being available to them at that point of time, or they forget to do. So that was those are some very, very challenging areas for looking at, the compliance to practice, the commitment by the healthcare professionals in ensuring these things being done, and commitment from the administration and the leadership in supporting these programs are the main challenges that I have faced. Of course, additionally, like what Sir was also mentioning, in the past it has always been older hospitals, older buildings converted into hospitals. So there used to be structural changes that need to be done. Like Sir mentioned, you don't have to change everything, but certain things you did have to, because when you need a unidirectional flow, you definitely need one, and you cannot store all your sterilized CSST good just under your AC ducts. So those are some things that you definitely have to change, and if you ask and tell, it is going to become very, very difficult also. So those are some areas of implementation challenges that I have faced. And vaccination, of course, is something, who pays for it, and who takes this cost, and how do we get it back, and all of these. I really like the idea what Ram Subramaniam sir said. I think government has to have a policy and ensure that everybody needs to be done. How it is done is also given as laid down as a path. So it becomes easy for everybody to do. Thanks to accreditation, that it ensures vaccination as per the biomedical waste rule, that everybody gets a hepatitis B and TT, and the food handlers get at least a typhoid and a hepatitis A. So these are the basics that are given, but I think they should still look at more specific vaccination for those who are handling as well. So these are areas which has been very, very challenging, I would have seen. Yeah.
During swine flu, H1N vaccine was given only for healthcare workers and the students and other people. And now currently, in addition to what Madam and Sir was telling, TD vaccine we are insisting, the tetanus and diphtheria vaccine. So now particularly the senior doctors, so they have not received, doctors and nurses who have not received earlier the DPT booster and DT booster. So now it has become very essential. The diphtheria cases are very much around. And as Madam said, to supplement, the behavior change is the most challenging. If any major hospital, if you go to the canteen or nearby hotels or some places, you can see the hospital staff, even as a senior person, moving around with the theater dress or with the hospital uniform, and also the street chapel practice. If you see at Singapore or Japan, so the street chapel cannot enter into the hospital. So the moment once enters into an hospital premises, they have to change over to the hospital chapel. And from the hospital chapel, and then they go to the specific areas, then again they have to change over to another chapel, whether it is an ICU or an OT or labor ward kind of places. So that, and also the visitor restriction, again, both the private hospital as well the government hospital. So for one patient, there are 20, 30 visitors. So that is why the most of the cities where there are a lot of government and private hospitals are located, say for example H1N or COVID-19, the Chennai, Vellore, Coimbatore, Madurai kind of places, they acted as the epicenter for these infectious diseases. Again, that is another challenge that we need to look into that.
Ram Subramaniam sir, your challenging experience.
I'll be very brief. It is said that the obstacle to progress is not ignorance, it is the illusion of knowledge. So when people think they know, when they actually don't know, it is the most difficult time to convince people. I'll just mention one brief episode which happened 25 years back when there was an outbreak of MRSA in the cardiothoracic ward. And that was a time when nobody knew much about infection control, and it was an MRSA. So convincing the surgeons, convincing the administration, and these are all very senior people, to listen to us and follow the protocols was the most difficult challenge. But once I was able to convince, the surgeons they all fell in line, and it was the best thing which could have happened. But it took a long time and a lot of effort.
Thank you. Thank you all. Studies indicate that the uptake of vaccine in adult population is less than 2%. I'm quoting this from your own paper, sir, Ram Subramaniam sir. I want to know the role of adult vaccination, how to combat antimicrobial resistance.
I'm a passionate advocate of adult vaccination. There are a lot of critics, but I believe that just like childhood vaccination has revolutionized the safety of kids and how they were able to need the vaccine not only to protect yourself, you ensure that you don't come down with these illnesses, for which you may require. A lot of them are viral illnesses, say the flu vaccine. You will end up getting antibiotics. So it is part of the antibiotic stewardship initiative. They avoid admission, thereby saving hospital resources, and again, the use of antibiotics and other medical interventions to keep them healthy. So you win in all aspects. Adult vaccination has to come. Of course, like any medical intervention, there are side effects. But when you look at the benefits versus the risk, I think it is something, you can die of a toxic epidermal necrolysis or a penicillin anaphylaxis. It's possible, it still happens. So similarly, the risk is very, very, I think it's an acceptable risk. So this is probably the way forward. This is something which I feel in India will make a dramatic change. And ICMR is starting a study right now very soon to look into this. And I hope we win and we are able to push this as an agenda, not only to help patients stay safe, but also for antimicrobial stewardship.
Yeah, and in turn, it would help the healthcare organization by reducing the number of people who get admitted and keeping the bed vacant for other purposes also. Thereby, it reduces the unnecessary admission to hospital related to communicable diseases. How can a private and public sector collaborate to promote infection control practices in hospitals and communities? So this question is to Ram Subramaniam sir and Porandaswamy sir. How can both sectors collaborate with each other to bring in this practice?
So, shall I?
Yes, sir.
Yes,
You
sir.
talk about the government side, I can talk.
So mainly training and sharing of facilities are on the one side. So like complementing each other. The main the collaboration can come for the surveillance, whether it is a syndromic surveillance or actually the causative organism, the AMR surveillance. Then it is very, very important that private and government to collaborate, knowledge sharing, training, mutually using complementing the facilities for each other, and the surveillance. These are all the areas where already some collaboration is going on. Still, there is a scope for further improving particularly from the government side, some kind of policy change and kind of decentralizing the powers to the district level authorities and other people, to enabling them to coordinate and with the private sector is very important. Yes, sir, please.
TB is a very good example. We saw during times of COVID, there was a lot of interaction between private and government agencies. Tuberculosis, as Dr. Porandaswamy said, the surveillance aspects, the diagnostic aspects, and also treatment. There are certain drugs which are available only with the government for treatment of tuberculosis. So there should be a system whereby they can interact so that both benefit and the patient, of course, benefits the most.
So how about a community education where probably the private and public can come together and walk out to the community, to the public, to create more awareness and education for the people? Well said, sir. Thank you. Role of surveillance and audits. Over to Jayalakshmi ma'am. Always the infection control practitioners or the IPC people who practice, they are always ridiculed that you walk around the floor with papers in hand and doing audit and surveillance. Does it have any role? Does it play any role?
One of the most important thing is to to see whether you're doing well is to measure. Okay, so if you don't measure, you don't know where you are, and you will never know where you will be also. So you need to look at how well you're doing. I'm sure we conduct assessment for our students to see where they are, to see whether they are doing well, have they done well, etc. So it's very simple, and all that we need to do in any of these audit programs is audit sessions or audit is to see how close you are to the standard. What is the practice and how close is it to the standard that is required? So so this is not to find fault in the system. This is just to, in fact, it should be in such a way that it doesn't find fault. It kind of helps identify areas for improvement. Also identifies those best practices that they do. So encourage people on doing. Also, it gives you a clue, an idea on why some things are not happening. We always say, okay, people are not washing hands. You never know whether that person is allergic to the hand rub. That's why that person doesn't wash hands. So unless you go in and look at, you will never know what is the actual problem. So these audits give lots and lots of information. So it's important that we structure our audit tools well. It has to be based, like Dr. Clive sir also mentioned, and Dr. Ram Subramanian sir also mentioned, that it has to be very tailored to the need of the whole hospital system. Each hospital is different. The private is different. The public sectors is different. The multi-speciality is different. The single specialty ophthalm only is different to that of obstetrics hospital. So you need to have a very, very structured, tailored tool, kind of looking at what you want to assess. You can look at one thing across the entire hospital or do everything in one area. So however you would want to do, make it very simple so that you don't complicate more of these issues. Sit as a team to decide and what you want to assess, and you look at prioritize areas that you would want to start and do these audits also. You don't have to do everywhere. You just can look at those areas which are important, where earlier we discussed about the risk assessment. So your areas of priority, so that you focus that area. Prepare a checklist which is very simple but comprehensive to hold every aspect of it. And then you kind of look at looking at the structural aspect of it, the little bit of the process or the procedural aspect of it, as well as the outcome aspect of it, and see there is a very simple way of documenting yes, no, or not applicable, so that it becomes easy for everybody. And train the people who's going to audit. That's very important. If I audit with an audit tool and you audit with the same audit tool, we should be giving the score same. If I give yes, you also give yes, and we don't differ in that, because that number is what is going to make the next set of program, because our risk assessment is based on these numbers later. So it's important that we capture it right. So standardize your checklist, your auditors also. Train your auditors, schedule your audits, pre-inform them if required, then conduct an audit and see what is the compliance. Always look at how well we've done, not looking at where all we've gone wrong. So not looking at it negatively also helps in the conducting an audit itself. And when you do an audit, it's always good to group them so that you will tell, okay, these are the trainings that are required. These are the resources that are required. These are the structural changes that we need to do. So we are able to group it so that our implementation becomes better. So based on that, you identify what is my implementation? What am I going to do as an implementation? Put down your implementation. See again to prioritize which is the easiest to perform, which is the first one to do. And once you do that, you re-audit. So no audit is complete without an implementation of find all your observations being looked at and addressed, and doing a re-audit to see that you have improved better. If not, what you have found maybe is not right, and you go back to see what's wrong. So this whole process helps in improving your system in one process to the other slowly. So this is definitely a very good activity, I would say. And audits and feedbacks will always help any system get better. So I am always for audits, and they may not. A lot of people may not like audits. They always find, but the way you do the audit. So that's why it's important you train your auditors well, so that it's more structured, as well as how they communicate the findings is important. If you accuse another clinical unit saying that you guys didn't do this well, then they're not going to allow you next time. If you say that you're doing these things very well, and these are areas where you could improve further, then that will be well taken.
Yeah. Point well taken, ma'am. The audit or surveillance is the actual way how we are going to reflect our practices. So reflection is very important. If we don't measure something, how will we make the change? So measuring is very, very important, and that's the way forward, and also make and update our practices. So coming to the last question of this session, over to Ram Subramanian sir and Clive sir. How to sustain infection control practices at the organization level all the time?
Okay, so I'll keep
I'll answer this.
I'll keep it very brief. People never do what is expected. They only do what is inspected. That's in a nutshell. So how many times, how many times have you seen your leadership wearing an I-card or punching their attendance when they come in? They don't do that. But when they see a down to the ground staff level, not with an I-card, they will ask him, where's your I-card? So people actually follow what their leaders do. So, walk the talk. So if you have to look at it, at 50,000 feet, walk the talk. I want leadership to walk the talk. Does leadership sit in your infection control meeting, or they come like Alexander? I came, I sat, I left. Is it a tea biscuit infection control meeting, or is there drill down? I have seen places where they say antibiotic stewardship. Dr. Ram, you'll be amazed. Antibiotic stewardship compliance 100%. And I said, you must be better than the best, because they struggle and everyone is happy, and that's the end. And when you start drilling down, you come to know, oh no, but what we did, we only tailor made it to the 60 minutes before incision, because they are giving for 5 days. They're not giving a single dose. So we remove that from the definition. Then we remove the places where they're giving and it's more than 60 minutes. So leadership, your role, the clinicians can drive it, they will drive it, but leadership right from the top has to be there, and has to walk the talk. When you sit in an infection control meeting, has anyone actually said, okay, before we move forward, tell me what were the follow-up points for the last meeting, and have they been closed? Have they been addressed? So these are some of the things, because I believe we talked so much about, incentives and all, carrot and stick. My firm belief is there has been too much carrot and there has been no stick at all. And, it is not working. And now we have to crack the whip, because some things like antibiotic stewardship, I'm so surprised. Everybody worth their salt will talk on LinkedIn about, and I'm not talking about us. You are the you're the infection control specialist. I have surgeons and everyone, they'll give big lectures on antibiotic stewardship. And when it comes to them looking at compliance for their own patients, they don't want to take a risk. So, how to sustain? People have to be involved. People have to walk the talk, and then accountability. We started with the word accountability. We end with the word accountability.
Thank you, sir. Ram Subramaniam, sir.
No, I perfectly agree with him. This morning, I was driving the car at a signal, and the green signal for us. And when we tried to cross, there was a car coming, followed by several other cars. And this was a policeman taking his son to school. He was sitting in a police car, all police, all written around, and he was in mufti, and son was sitting with the school uniform next to him. And I said, if the police is doing this, how will anybody respect them? So I perfectly agree with Clive that it has to come from the top. You cannot expect change to happen just because you tell them to. People look at you and then respect you for what you are. So this has to change from the administrative side, from the top.
What about the institutional safety climate, sir? Are people afraid in the institution to come up forward and tell that this is not happening? Probably they'll be sued. So
it all comes again to the leadership. If the leadership is tolerant, if the leadership, encourages people to, vocalize if there is a problem and sorts it out, that helps. But if they're going to be penalized, I always tell you, my feeling that the nursing department, unfortunately, is very, very hierarchical. And if somebody says something, one word out of place, immediately the top brass shoots them down. It has been like that. I can see changes now, but it still has to go along. So the client, only then it will change, along with, of course, accountability.
thank you. Any more points from Swami sir, Jayalakshmi madam? How to sustain? That's the biggest challenge what we have now.
So I totally agree to both of them. Leadership is the key. Okay, role models are a must. And if it's the leader who's a role model, then again, that's the best. The infection control team have to be very patient, persistent, I would say, because there is a batch that keeps coming. There is a new set of people who need to be trained. So it's a continuous process, and there is a new change that happens. It's very important that all of us need to continuously learn, unlearn, and relearn. As we upgrade ourselves, and because it's a ever learning process that is in infection prevention control. So there is new thing that keeps coming, and it's important that we upscale, tell everybody, and ensure that it is happening. And then like again the audit and giving the findings to them, helping them. Once they see one of their cases, like what sir said, the cardiothoracic team, completely brought in because of what they had faced and what was addressed. So only such scenarios help them also. So it is going to be tough, okay, for the team, but need to be working hard. The leaders are now better than what they used to be in the past. So definitely there is a change. So I think it's good and it'll go strong, I feel.
Thank you, ma'am.
Dedicated infection control personnel are very important. So in our experience in Coimbatore district and the Tirunelveli district under the CDC and CDC project, a single well-trained infection control nurse was able to bring in a lot of changes. So this we keep trying to convince the government and authorities to allocate a dedicated person or a team depending on the size of the hospital. So that will make a lot of change in infection control practices in the hospital setting. And another important item which I find in most of the audit checklist and the infection control protocols, what is missing is the water. So the water, what is the type of water which is supplied into the hospital and how it is treated and how this water is used in the labor ward and the neonatology theater and other places. So that should find a key place in the audit or other checklist or inspection checklist. Similarly, as I was mentioning already, the ventilation very important. So we were talking about the COVID-19, so many healthcare people perished in that. If you look at that mortality, so the major proportion came from the higher level facilities for the simple reason, the ventilation. So here hundreds of camps had been conducted by the corporation, the municipality, and the primary healthcare staff every day, because they conduct the camp under a tree or in an open place, and they wear the PPE and they follow the hand wash and disinfection procedure. The infection rate, the mortality rate, there is a huge difference in the hospital setting and the field setting. So the simple reason is the ventilation makes a lot of difference. So the ventilation, water, the dedicated infection control team are all very important we see in our setting.
Thank you, sir. So summarizing the points given by all the panelists, to make infection control practices more adaptable and sustained in our country, walk the talk, make everyone accountable, avoid the chalta hai business, make everyone accountable for infection control practices in the hospital, have a very strong leadership support, customized risk assessment, which should be tailored for each organization, and accordingly, resource allocation. And when you customize it, look into the quality monitors, look into the risk assessment, and always involve a multidisciplinary team. Let it be an engineering support, a housekeeping support, a maintenance, or even the COO of hospital. Each and every person who is important to bring in infection control practices has to be involved. Occupational health carries a very important role when it comes to infection control practices, and we would send out a message to the government to drive this vaccination protocol, not only for the healthcare workers, but also as adult vaccination program in the community. Focus more on infrastructural development, particularly upskilling the microbiology laboratory, which is more accessible and easily available for the people available on the floor. Catch them young, train the newcomers when they come into the organization. Let it be doctors, nurses, or anybody who walks to the healthcare organization has to be trained. Regulation of things from the government plays a very major role to keep things at par all the time, and standardization and reporting mechanism would definitely help us to sustain the infection practices in the organization. Because as we all know, No country, no healthcare system, even the most developed or sophisticated country or the organization, either developed or underdeveloping or developing, can claim that they are free of hospital-acquired infection or antimicrobial resistance. So it has never been more urgent in this era where antimicrobial resistance and IPC practice, which are now important and also for the future. So I would like to thank all the panelists to guide us, to help us, to understand us, how infection control practices can be accepted, adapted, and taken to the next level. Thank you all once again, and have a very good evening.
I would just like to make a brief mention. I really place on record my commendation and congratulations to Dr. Ghafoor and his entire team, including you, Dr. Yamuna, and the AMR Trust for bringing to light sticky issues which we need to talk about and help probably formulate policy decisions, which is probably beyond our reach. And Ghafoor, well done. Keep it up.
Thank you.
Thank you. Thank you.
Thank
all
you
the-
very much. Thank you
all
all.
the esteemed panelists and for participating in this webinar. Extremely useful webinar. And thank you, Yamuna, for coordinating this meeting in a wonderful way. Thanks a lot and good night.
Good
Thank
night.
you.
Good night.
Thank you.
Bye-bye.